you for the introduction. Thanks very much. Can I just make sure you can hear me okay and see the screen all right? Good as well.
Perfect from my side, Sara.
Awesome. Okay, well, thanks very much for giving me this opportunity to talk today. Today's talk is basically part of this national core study on ethnicity, equity, and AI that we're doing as a collaboration with HDR UK. And so I suppose by way of background, we have figures such as these, which sort of just go to highlight the fact that inequity in health is something that was highlighted by the COVID pandemic, where people from ethnically diverse backgrounds were disproportionately affected. And we have Kamlesh on the call as well, who did some awesome work on this, actually. But we know this inequity is not limited to COVID. It's a long-standing, multifaceted, international issue. One factor in equity is that of the contribution of health technology to this. And so an example of that maybe is AI technology for clinical risk prediction. So in brief, this basically involves something like the use of routinely collected anonymized patient data, which is fed into an AI model. And that model in turn produces a health risk score for a patient. That score is then used by doctors to decide patient care. Now, if there's bias in the data underlying that model or bias in the modeling process itself, doctors can potentially make wrong decisions, and patients can get the wrong sort of care or even no care at all. And so today's talk is about the idea of the underlying data and the idea of investigating whether the correctness, completeness, and granularity of ethnicity information in routinely collected data can be improved. And that's at the heart of any models that are then kind of decided or built to be ethnicity specific. So in terms of the data sources involved, we use the UK trusted research environment databases, but this talk focuses on NHS Digital only, which contains 61 million or so records from all of England, with linkages with hospital records, COVID databases, and ONS data on mortality and deprivation. These access to these data are provided by the HDR UK Gateway, and that's coordinated by the COVID Impact and British Heart Foundation data science teams. And then as an external validation, the analysis is planned to be validated in data from Wales as well. So looking at ethnicity data just within the NHS Digital TRE, there are mainly two forms of ethnicity codes available. So the one is what's called, or what we are calling as primary codes. So these follow ATIS notation that follow, broadly speaking, ONS census categories, although there's no official mapping of these to the groups in census categories. And the main sources for primary codes within the TRE are GDPR, which represents primary care data, and HES, which represents hospital admission records. And this contains ethnicity groups according to the 2001 census. Then the other form in which ethnicity information is captured in TRE is via Snomed Codes. These are only present in the primary care database. So, and there are, although there are nearly 500 codes, only about half of them are actually used in patient records. If we consider the definition of Snomed Codes, there's quite a lot of variety there as well. So some capture information about race, whilst others about religion, country, language, etc. And as an example of one type of definition on this map, as you can see, there's about 80% of the Snomed codes contain the name of a continent or a country, but not all do. So the way the mapping works is something like this. So the probably the lowest level layer is the Snomed Codes. These are then mapped to the primary codes that are available in both GDPR and HES. And then the research community typically will group or collapse the primary code, ethnicity codes, into something like the summary ethnicity groups that we can see on the screen at the top. And this is maybe one way to visualize this sort of mapping. There's an interactive view visualizer as well that's available on the study website for this. So looking at some of the numbers and some of the investigation from the point of view of completeness, correctness, and granularity, what we see is that out of a total of 61 million patient records in GDPR, so the primary care data set, there is at least one ethnicity record for about 86% of individuals in primary care. So that's the box in the red. And so in terms of the distribution of ethnicity groups within that, compared to 2019 census estimates, and we don't have those yet for 2021 census, the proportion of, there's a lower proportion of those with white ethnicity, or those belonging to the white ethnicity group, about 10% lower than census. So here it is 77% for the 53 million individuals. And the proportions was somewhat higher for mixed and other ethnic groups as compared to census. And this is bearing in mind that in these data, 3% of people had a not stated ethnicity. And also that these are just numbers from England, whereas census data is based on England and Wales as well. So for the 14% individuals who did not have any form of ethnicity code in primary care, the first approach was to try and extract or link with HES and other COVID data sets that were considered to be quite complete on ethnicity information. And HES linkage reduced missingness by 10%. So in short, from a total of 14% of people who would have no ethnicity record in GDPR, that number goes down to about 4%. We also found that additional linkages, such as with the SGSS table, the COVID tables, did not offer much further reduction in terms of the missingness. But when we look back and compare with traditional databases with routinely collected data on ethnicity, the numbers that we see here are already an improvement, which says something about the quality of reporting in the first place, also, although that's somewhat out of scope of today's talk. Now, in terms of looking at individuals with ethnicity information and those with no form of ethnicity information, or those for whom ethnicity was stated as either not recorded at all or not stated. We see that, generally speaking, and this confirms with what we know from literature, that those without ethnicity records were generally younger. There were more males in that group, generally less comorbidity, so healthier. And where there was missingness in ethnicity, there was missingness in other indicators as well. So overall deprivation, missingness was high in deprivation and body mass index of the variables that were considered thus far. And so this kind of can be seen in this figure here as well, where missingness peaks in the 18 to 29 and 30 to 39 age groups, and then goes down across the age groups. We also looked at missingness by region, although this is, I appreciate, quite a high level view of this. And as compared to those without any missingness, there seemed to be more missingness in ethnicity in the southeast regions of England. Again, this is something that we know from some literature on this. So in terms of correctness, the way we looked at this was to look at multiple ethnicities, potential discrepancies in mapping. So to look at multiple ethnicities first, in short, about 17% of ethnicity records in GDPR, the primary care data, had multiple ethnicity records for one individual, whereas the number was more than double that, or the proportion was double that for hospital admission records, as one can possibly anticipate. And so there was more consistency, this goes to say, in ethnicity records for an individual in primary care data as opposed to hospital-based data. Looking a little bit closer into who were the multiple ethnicity groups, or what were the multiple ethnicity groups in multiple ethnicity records, on the left, onto your left, you will see the overall distribution of ethnicity groups in the multiple ethnicity records. And on the right, we see the most common pairs, where there were multiple ethnicity records. What were the most common pairs? And so here we see that if we discount for a moment white ethnicity codes, because those were, the most common even in those with multiple ethnicities, but perhaps not the most interesting ones to look at. So if we discount those, we see that the multiple ethnicity pairs look something like other Asian and other ethnic group, African and Black background, and so on, as you can see on the sort of list to your right here. More or less, what we found was the multiple ethnicity groups were correlated, or different ways of defining, the same or similar ethnicity categories. We also looked at potential mapping discrepancy. So when mapping was done between Snomed codes, primary codes, and high-level codes, how does this look like? And so this is just a zoomed-in version of the same diagram as before. And the group that most of the potential kind of discrepancy was found was the other ethnic group, as one can imagine. There's quite a few. There's a variety of heterogeneous groups that are often lumped into this group was found. For instance, Gypsy or Irish traveler and Chinese all mapped into this one. And so this diagram here is just to give a sense of what were found to be Snomed level groups that are currently mapped to a certain primary code on the left of the screen, but they could well be potentially mapped to a different group. And perhaps the one to maybe focus on is the group of, for instance, Asian and Chinese and New Zealand and European. These are all mapped into other ethnic groups at the moment, but they can potentially be separated into other categories. And then moving swiftly into granularity, this part of the work sort of raised more questions than provided answers, in the sense that does it even make sense to look at or to analyze deeper or more granular groups, even if they are found to be there in the data, than higher level groups? And how deep is deep enough, where we know that ethnicity codes are more than 250 of those in use. Perhaps if you look at this diagram here, some of this comes out, where looking at subgroups within the group, other ethnic group, which is 55 subgroups just there, we found that some of these were potentially maybe large enough or distinct enough by definition, such as the ones boxed in the red boxes here. But could these be used could these become the focus of dedicated research questions? The subject of sample size, is the subject of the question, the research of interest here. We're just quickly looking at another of the non-white groups. In this case, the Asian/Asian British. Here too, there were more than 55 subgroups here, but we're looking at the top most common ones, which were I think Asian, Indian, Asian, Pakistani, Bangladeshi, and Chinese. No, not Chinese. Sorry, just the other three ones. And the idea being there, the fact that these subgroups are there and the numbers are perhaps large enough is exemplified by this, going back to this kind of this first slide, which sort of shows that sometimes, there is devil in the detail, and in fact the nuance in COVID mortality risks was indeed brought about by experts like Kamlesh and colleagues who started looking into the individual subgroups and found that indeed there's a differential within the subgroups. So there is some value in looking deeper, in addition to just looking at higher level ethnicity groups. But I'd like to move towards wrapping up now and just say really briefly that PPI and representative, ethnically diverse in this case, PPI was paramount. In this case, our PPI team members, focus groups, and stakeholder case studies, they're all integral to informing the study design. Essentially, for instance, helping the study design move away from imputation or inference towards linkage. But linkage was also possible because, that there are, as we see, 94% of individuals had ethnicity records they could be completed after linkage with HES. So there's something to say about, data quality there as well, and making linkage be the more feasible option here. But all in all, the idea here is to investigate, understand, and improve on the way the data are organized, in this case, ethnicity data, with the idea that with better ethnicity data, it can lead to better models and ultimately better healthcare research. Of course, there's some limitations. We are looking at just GDPR as a base data set and then using that as a base, linking with other databases as required. And there's some information on the study website on this. I'm happy to take feedback now and discuss with others, just thanking the study team, acknowledging HDR UK for their support. So thank you very much, Lynn and Annette.
Thank you very much, Sara. That was a very interesting presentation. I'm sure everybody will agree. There's lots of takeouts from the detail in Sara's presentation. We do have a few questions in the chat, Sara. One from Ashley. Do you plan on expanding your use of data outside the Snomed coded 2 data sources you currently have mentioned to get further ethnicity records from other data sources in England?
So we've used Snomed, we've used primary codes, and we are looking forward to having a discussion with you actually as to how else this can be extended. And I was wondering if someone could kick me out of the slideshow so I can go back to seeing people's faces actually, which I can't seem to be able to do myself. Great, thank you.
We've also got something from Gary Coleman. I note the geographic distribution of ethnicity missingness and the related attributes. It feels very similar to those attributes reported in relation to opt-outs, which presumably applies to the GDPR data. Could you comment? And also from Joanna, can you say a bit more about how the combined HES primary care compares with the self-identified census data? And is there an opportunity to link to census as well?
I could probably take the second one first. And so bearing in mind some of the differences between this analysis and census data, in that this is England only, whereas census data is England and Wales. England and Wales census data did not seem to have any missingness, whereas we found that there was missingness in these data, about 3%. and the fact that this analysis is looking at everyone who may be dead or alive up to the year 2022, but census data is obviously restricted to those who were alive at the time of recording the census. So some similarities were found, but the main differences were found in the white group. There's about 10% drop in these data as compared to census. And there's an increase in, or the high proportion of mixed and other groups as compared to census data. Opportunity for linkage, I think that is under discussion. It's not straightforward, but I don't know if Rose and colleagues from ONS are on the call, but there's definitely some work ongoing in the ONS teams to look at this.
That's great. Thank you, Sara. Anyone else have any questions? Everyone seems to be putting them in the chat today.
I'm happy to tackle some of these in the chat.
Where the ethnicity other than self-reported census data comes from. For example, is it self-reported by each individual by filling out a form?
So the self-reported data, the data used here are all data that are recorded by at the point of need, so at GP practices or in hospitals, when patients fill out outpatient forms. So these wouldn't necessarily be self-reported in that sense. There was a previous question on opt-outs, which I wasn't quite sure what was meant by opt-out in this case, but perhaps we can take that question offline.
Gary, are you there? Would you like to come in and ask a question direct to Sara?
I see Ashley has a comment about the kind of, the need for an update on the census data, and I totally agree with that. The 2021 census data is what everyone has their eyes peeled for, and as I understand, it is to be made available, but not quite there yet. So what we have to compare with is 2001 actually, and just some estimates and projections of that up to 2019. So not ideal, but just something to work with, I suppose. Gary doesn't have a microphone, so maybe Gary and I could chat about his question offline.
Kamlesh, you've got your hand up.
Yeah, thanks. It was just a comment regarding self-assigned ethnicity. As Sarah has mentioned, all of these data come from primary care or specialist care that has data. And this is where patients would be asked, but sometimes the patients aren't asked. The receptionist will just assign an ethnicity code because they're doing it so quickly. So there will be some inaccuracies there. And that's why it'd be good to look at this with the 2021 census data, as Ashley's already mentioned, to see what the accuracy of this coding is.
Thanks very much, Kamlesh. So the opt-out they're talking about, Sara, is where the people have opted out of having their data used, and it seems to correlate with the GP opt-out. How is that affecting? Have you factored that in?
So we didn't have an opportunity to investigate opt-outs as such, but what we did look at is a breakdown of the missing data group into those who had stated for whom an ethnicity code had been recorded, but that code said ethnicity not stated. So that's possibly as close as it gets to the opt-out group, and compared that with those for whom no ethnicity had been recorded at all. And so there was a slide that kind of showed that comparison. But yeah, I think on the whole, we found those who kind of opted out in that, by that definition, to be healthier, younger, and generally kind of less well recorded with regards to deprivation, body mass index, and other health questions as well. Awesome. Yep.
Yeah, and yeah, Gary's put his email in the chat, Sara, if you want to discuss further with him. Thanks, Gary. Jackie, did you want to just come in on a final point?
I think Jackie's question.
Oh, yeah, sorry. Yeah, I was asking about this really because I was wondering how much of it is self-reported and how much of it is where, you know, some medical professional kind of takes a look at somebody and, you know, fills out that information, because that will obviously be probably a lot of it will be dependent on like kind of colour of skin, that kind of thing, which doesn't necessarily correlate that well with ethnicity or ancestry. So I was just wondering if the census information is more likely to be accurate if it's self-reported, and whether it would be an interesting analysis to compare how often there's kind of a significant difference in ethnicity between what's reported via, you know, or what's included in other medical records versus census self-reported.
Yes, so census versus self-reported. Yes, I think the approach has been to consider the census breakdown as gold standard, assuming that is what is most representative. But there is something to be said about within these data that are collected at healthcare services, how much of them are self-identified by patients and how much are typed in by the receptionist or just kind of assumed by the GP. I don't know the answer to that because we're looking into the data, and there isn't a field in the data that says whether that ethnicity was assumed, reported by the GP, or by the receptionist, or penciled down by the patient themselves. But what we do know from various PPI discussions with patients and public representatives is that it would be expected that most of at least the GP record data is that which is self-reported by the patient and done once at the point of registration, or and obviously if the patient moves practice or re-enters the system, then it's done again by them. But by and large, that's what it should be. It was surprising to see that there is discrepancy within that as well. So there are multiple ethnicity records just for one individual. So where those come in, probably there's something that we don't quite understand fully about how this is, how the data is being recorded and how it's entering the database. But yeah, definitely, we know from literature that there is something about inference, assumptions, and some of it is patient self-reported, some of it is assumed and recorded by others on their behalf.
Yeah, that's really interesting. Thank you.
Thanks, Jackie. Thanks, Sara. There are a few messages coming through in the chat, Sara. There's something about how the census declarations have changed from Ashley, and Florence has asked a question as well. I'm going to leave you to have a look at those while we're going through to the next